Let me welcome our attendees today. I am so excited to welcome you to the second lecture in our annual lecture series on the history of medicine and ethics, and to introduce you to our speaker today, John Harley Warner. It's a great honor. Professor Warner is a great historian who focuses on the transnational history of medicine and science, received his PhD in 1984 from Harvard University, and then in 1984 to 86 was a postdoctoral fellow at the Wellcome Institute for the History of Medicine in London. In 1986, Professor Warner joined the Yale faculty and currently is the Avalon Professor of the History of Medicine and American Studies in the Department of History, and is also the Chair of History of Medicine at the Yale School of Medicine. Professor Warner's research interests are very widespread. They include the cultural and social history of medicine in the United States from the 19th century to the present, and also, as I said, transnational and transcultural comparisons. He's particularly interested in the history of medical education, clinical practice, the doctor-patient relationship, and visual cultures of medicine. Professor Warner has written many books. I fell in love with the first book that he wrote called The Therapeutic Perspective, Medical Practice, Knowledge, and Identity in America, 1820 to 1885, published by Harvard University Press. And then 10 years or so later, that was in 1986. In 1997, it was picked up by Princeton University Press, I think for the soft cover volume that I've read 3 or 4 or 5 times. Some other books by Professor Warner include Against the Spirit of System, The French Impulse in 19th Century American Medicine, another book called Major Problems in the History of American Medicine and Public Health, another one called Locating Medical History, The Stories and Meanings, published by Johns Hopkins University Press. I could, go on, but let me say that Professor Warner's current projects include Bedside Stories, Clinical Narrative and the Grounding of Modern Medicine, and he's currently working on a book entitled The Quest for Authenticity in Modern Medicine, which traces what was being lost or placed at risk of being lost in the late 19th century emergence of a new version of laboratory-based scientific medicine. I'm looking forward to these books that he's working on currently. Today's talk by Professor Warner will be Narrative at the Bedside, the Transformation of the Hospital Patient Chart in the 19th Century. I'm eager to hear it. I hope that the lecture goes on, and then we'll open it to questions. Either do the questions in writing, or if you wish, you can do them verbally at the end of Professor Warner's talk. John Warner, it's a delight to welcome you here for the meeting. Thank you so much.
Well, thank you for the very kind words. And let me just share my screen. Does that look like it should look?
Perfect.
Okay. Thank you for the kind words in the introduction, and especially thanks to Drs. Sigler and Schwartz for the chance for me to try out some of my ideas on you and see what you think. I should say at the outset that what I'm presenting here is not work that I've published, but I do expect it to be part of a chapter in that book, The Quest for Authenticity in Modern Medicine, that I'm working on now. So all of that is to say that if there is time, I would really welcome your thoughts about resonances that there might be between the story I'm telling, which ends about 100 years ago, and the clinical world that you inhabit today. My focus here is going to be on the formal transformation of the hospital patient record over a long 19th century, how we can explain it, and more broadly, what we stand to gain by thinking about the practice of writing as a medical practice. A professional activity that served many ends, institutional, clinical, pedagogic, legal. The production of clinical narrative, that is the clinical practice of writing, was also a kind of performance that for some physicians was important, not merely in fostering careers, but also in expressing and establishing professional identities. And part of what I'd like to suggest is that changes in scientific knowledge and medical technology, at least as those categories most conventionally have been approached, may not have been as responsible as historians have assumed, or in the ways that we've assumed for transforming depictions of the sick. And I particularly want to reconsider the role that experimental laboratory science played in reshaping clinical representation and through it, clinical cognition. I also hope to persuade you that we need to kind of thoroughly rethink how it was that the experimental laboratory first entered and altered practice at the bedside, as well as the social, epistemological, and ethical meanings that had been identified with that process. Most especially, though, I want to suggest how this transformation in clinical narrative took part in making and expressing a new kind of professional identity among doctors. Now, we have a sort of readily available framework for explaining changes in representations of the sick, one that's long-standing but still historiographically salient. During the 1960s and 70s, in sort of challenging a linear master narrative of medicine designed to display progress, many historians began to embrace a darker story that held science largely responsible for the dehumanization, as it was often put, the dehumanization of modern medicine. According to this view, the rise early in the 19th century of hospital medicine and later of laboratory medicine fueled a process that the historical sociologist Nicholas Jewson rather famously characterized as, in his words, the disappearance of the sick man from medical cosmology. The French philosopher Michel Foucault, for example, in his book, The Birth of the Clinic, argued that it was in the Paris hospitals just after the French Revolution that the individual sick person was decisively converted into a disease entity to be studied like any other object. Ethicist historians like Stanley Reiser pointed to the stethoscope, the best known creation of the Paris Clinical School, as the first significant technological wedge between doctor and patient, a device for bypassing the patient's words. And Jewson held the rise of hospital medicine in Paris responsible for, again in his words, eradicating the person of the patient from medical discourse. This, we've been told, was the inception of a larger process clinched in the final third of the 19th century by a swamping of clinical medicine by laboratory tests and the reductionism they represented. Well, it was with this larger, darker, grand narrative in mind that I first began systematically reading surviving American hospital patient records from the first half of the 19th century. So I was surprised to find absolutely no evidence of the change that I expected. Jewson's sick man was remarkably tenacious throughout what's been called the Paris period in American medicine, that is the 18 teens through the 1850s. The distinctive voice and person of the individuated sick man and woman remained persistent parts of clinical discourse. By the 1870s and 80s, though, things had changed, and rather decisively. And it's that latter shift in the patient record that's going to be my main focus here. I want to draw into question both the animus and meaning that historians have ascribed to this process. But really more than this, I want to suggest how a fundamental transformation in clinical narrative, standardized to a remarkable extent by the 19 teens, took part in making a new kind of professional identity and setting in place one cornerstone of modern medicine. Now, I don't want to dwell here on the first half of the 19th century. I do actually, I live in the first half of the 19th century, but there's no time. I just say that I've drawn here on all of the major collections I know of medical, though not surgical or psychiatric, records that include the first half of the 19th century. Continuous runs from the Massachusetts General Hospital in Boston, the New York Hospital, and the Commercial Hospital of Cincinnati, what's now the Cincinnati General. More scattered records from New Orleans, Charleston, Philadelphia, and Hartford. These records were inscribed by an aspiring elite of recent medical graduates serving as resident or house physicians. They had something to do with patient care, but everything to do with the hierarchical power structures of hospitals. For these young doctors, writing a case record in a certain way was a kind of performance designed to please and impress the senior visiting physicians who could make or break their career. Well, at the same time, it told them something important about who they were. There may be no such thing as a typical case, but let me give you one concrete example. This is the opening page of the record of a 28-year-old stonecutter, John Matthews, a pseudonym that I've assigned, admitted to the Massachusetts General in the winter of 1823. He remained for 2 months, not untypical at the time, and his record filled 12 long pages in the bound record book. And what I want you to notice here is the visual impression that the document makes. I mean, I know you can't, I was going to say, I know you can't read it, but maybe with Zoom and this magnification you can, but I don't especially want you to. What I want you to take away from this is that what we have in front of us is a page full of words. We are routinely invited to read a picture like a text. I instead want to ask you to look at this text like a picture. Like calligraphy, these records were not only read, but also viewed and experienced. The first page is a single long paragraph, and subsequent blocks of prose begin with each new day. And the only significant breaks are for therapeutic instructions. This history opened with an account of how it was that Matthews fell ill. 3 days ago, took a severe cold and neglected it 3 weeks, keeping at work. And then day by day, the house physician drew on Matthews' report in constructing the clinical narrative. And this overall visage was absolutely typical. And through mid-century, both the formal character and narrative structure of records like these were to change remarkably little. First-person narration by the patient is uncommon, but it can be found. I took a great many pills, but to no purpose. The resident physician recorded one man's words at the Mass General. And another quoted a butcher, in his words, accustomed to drink gin in the morning and to sip it through the day. What's equally striking, though, are the idiosyncratic voices of individual physicians who often made their subjective, judgmental, sometimes disturbing reactions part of the clinical history. Just as sometimes they wrote about their empathy for the impoverished sick men and women in front of them who simply had no place else to go. Thus, in opening the record of a woman admitted in 1847 to the Cincinnati Hospital, the physician wrote into the record book, "She is in a wretched, vile, stinking, disgusting state." Another wrote, the patient is unable, from natural stupidity, to give any account of his sickness. And at the end of the record of a 13-year-old prostitute, that's the physician's description, a 13-year-old prostitute admitted in 1846 for gonorrhea, the resident physician added, that is, wrote into the official record book, by the way, she would make a very nice go, explicit sexual reference. In any event, were there time to go into the both wonderful and unsettling detail these records display, we hear patients' stories in, for example, their accounts of what brought them to the hospital, which often said less about physical symptoms than about social circumstance, and of what they had done for themselves therapeutically. These records give a splendid, though little used, wedge into working class medical self-help. But what's clear enough is that clinicians made listening a key element in constructing a narrative in which individuated sufferers and healers often found a voice. I guess let me just add one more point about these early records, even though it's not rooted in the kind of evidence that historians conventionally regard as persuasive. And that is that the historian who reads them, at least me, can't help but be drawn into the lives of concrete, fleshed out, imaginable individuals. And I suspect that this emotional, subjective reaction isn't irrelevant to making historical sense about what these narratives convey. In these texts, individual sick men and women seem far from having disappeared. By the 1870s and 80s, though, the reader learns vastly less about the idiosyncrasies that distinguished among sick individuals. More important for my point, the individual doctor's personal voice was also muted, conventionalized in ways that expressed an ideal of detachment. And the physical documents themselves look different. And this, from Cincinnati, is as exemplary for 1880 as the case of John Matthews was for the 1820s. Instead of a long paragraph, the entry history is fragmented: family history, previous history, present trouble, physical examination. The patient story is separated off into two discrete sections: has always had good health, no new history, and present trouble began 3 days ago with pain in chest, dry cough and dull constant headache, anorexia and general malaise. We hear no daily report from the patient, and for nearly a week, the only entries are pulse rates, temperatures, and 1 urinalysis report. In the second page, the impression of standardization and freedom from patients' words is even bolder. A printed form enabled graphical representation of change in respiration, pulse, and temperature. And then down beneath the grid, a schematic figure permitted precise localization of the pathological disorder. This record was terse in the extreme, though, and what I've shown you just in those 2 pages is the entire history of this laborer's 40-day stay in the institution. Changes in medical theory had given doctors reason to believe that they, unlike their predecessors, need not lavish attention on the idiosyncratic characteristics of patients, that is, ethnicity, moral habits, social situation, and the like. In an earlier study, I used language as one mirror of broader changes in clinical mentality. What's up on the screen comes from a sample of about 2,000 patient records from the Massachusetts General. And the virtual replacement of the term natural in the records by the term normal reflects a fundamental shift in the ways that physicians conceptualize disease, from a disruption in a natural condition, something that can vary from person to person, to a deviation from fixed norms. I think it's much the same transformation that we see going on in the body of the clinical chart itself. Printed forms with regimented categories were, as one physician put it in 1874, a remedy for discursiveness. I love that phrase, a remedy for discursiveness. What we once learned about patients' life histories and experiences are largely gone, as are most judgmental comments about drinking, sexuality, or sloth that once had displayed how doctors sometimes felt about their charges. Indeed, by the mid-1870s, most patient records had shrunk down to a couple of pages and conveyed rather little sense of the person whose disease is being monitored and managed. And let me just say really plainly here, I'm talking about a particular historical moment without at all questioning the crucial role of listening to and witnessing the patient's story in many doctor-patient encounters today. Quantification also loomed larger, becoming prominent only in the mid-1860s. Early in the century, some information, pulse and respiration rate, was expressed in quantified terms, but nowhere were quantified gauges prominent. That started to change in the mid-60s when quantified temperatures first started to be inscribed, and statements of temperature, pulse rate, and respiration rate soon started to be clustered together in daily entries that constituted sort of virtual charts, as in this from Cincinnati. And all of this is drawn into the still bound record book. Laboratory test, chemical test, and microscopical examinations also entered the record around mid-century. Yet through the 1880s, the only laboratory work conducted with any real frequency was urinalysis. Occasional sphygmographic tracings, examinations of blood, and bacteriological reports also appeared. But even by the 1880s, laboratory tests played only a very small role in this clinical world. Their later domination of the clinical case, and this is really the point about chronology I want to emphasize here, their later domination of the case came after, not before, the patient's voice had been substantially muted. The most striking changes here were not in the clinical information physicians gathered, but in the ways that they presented that information, the formal aspects of the narrative. The most powerful new way of narrating change was graphical representation, which followed closely in the wake of the thermometer. Early in 1866 at the New York hospital, only a few months after the first quantified temperatures were recorded there, a physician sketched this grid into the bound record book and plotted onto it temperature and pulse rate. And I think you can see here how self-conscious physicians were about using this new instrument, this new technology. This from Cincinnati is labeled up here at top, thermometric range, not temperature range. That is a reference to the instrument rather than the information that you get from it. And this, with temperature plotted along here, ended abruptly when a no doubt chagrined physician wrote, I don't know whether you can read it on the side, broke thermometer. This apparently was the only thermometer in the institution, and for the next 6 months, no other quantified temperatures were recorded. This, of course, was a junior physician in a bit of trouble. Graphically representing temperature seems to have prompted doctors to plot for the very first time pulse and respiration rate as well, information that had been part of the record for decades. At first, this was entered at the bottom of the temperature chart, as you can see here at the bottom of the screen, but not plotted. Yet as early as April 1866, one finds in New York records several graphs clustered together under this new heading, Record of Vital Signs, possibly the first use of that term, which I think clearly marks how physicians conceptually group this newly represented information as a fresh technique for monitoring and displaying vigilance. Improvised grids appeared occasionally into the 1870s. Here again, somebody has taken a ruler and marked this into the bound record book. But very soon they were replaced by standardized printed forms. At the New York Hospital in 1866, in July, scarcely half a year after that first hand-drawn grid, we find this full-page printed form labeled Record of Vital Signs, which later that same year, the house physician, published as a model. This same visual impulse is clear in diagrams of the body, which also at first were drawn by hand and appeared just after graphing did. In this 1869 Mass General record, red and blue pencils indicate the localization and the nature of the disorder. And like the hand-drawn grids, they too were supplanted by printed forms. What's on the screen are actually printed slips of paper that were then pasted into the bound record book. So printed forms, or at the Cincinnati Hospital here and the Mass General here, a rubber stamp, like a business stamp that you could imprint. This is just a close-up of what you get. What began to be called the medical chart for the first time did not present clinical information that was fundamentally new, but it offered a way to express visually what before had been related in prose. And I do think that this shift in terminology from patient history to clinical chart itself signals an important transition. Okay, so between the first and final thirds of the 19th century, the formal aspect of the clinical case record had been transfigured. It was standardized, streamlined, and terse, and favored quantification and visualization. So how do we account for this change? Why did it occur when it did occur? Technical innovations like the clinical thermometer introduced new elements, as did the graphic methods of figures like Carl Wunderlich and Etienne Jules Marais, but these hardly account for the wider shift. We might expect it to correspond to a second stage in Nicholas Jewson's Disappearance of the Sick Man, what he calls a move to laboratory medicine. As Jewson put it, I'm quoting here, by 1870, medical practice had become an appendage to the laboratory. But again, that's just not what I find in American hospital records. Before the 1880s, with the single exception of urinalysis, there simply were no laboratory tests that loomed terribly large in American hospital practice. The transformation I've been talking about came before any significant routine reliance on laboratory procedures. The key shift then was not so much in new practices of gaining information at the bedside or in the laboratory, but rather in clinical representation. Again, the clinical practice of writing. Regarded this way, I would suggest that the laboratory was crucial, not though as a place where a multitude of tests were performed that somehow swamped perception at the bedside, but the experimental laboratory as the embodiment of newly emerging models and aspirations. Starting in the 1860s, as more and more American doctors traveled to German-speaking centers to study the emerging clinical specialties and experimental laboratory sciences, many returned consecrated to the vision of a new kind of scientific medicine. The laboratory, as they depicted it, stood for exactness, rigor, precision, and uniformity. And these ideals informed a plan to liberate medicine from its tedious preoccupation with the idiosyncrasies of individual patients. The exact method, the leading hallmark of laboratory science at the time, would, they hoped, make clinical medicine an exact science. Well, that plan was vastly overblown. Yet if the technical procedures of a laboratory, specific chemical tests, for example, initially made little difference to the workaday routine on the wards, the laboratory nonetheless found expression at the bedside through the verbal and visual languages of clinicians and the value system that their deployment of those languages embodied. Experimental laboratory science, I'd argue, did alter clinical practice in significant ways long before it affected change in the practice of, say, medical therapeutics. The ideals of the laboratory entered clinical work through the activity of writing, the day-by-day inscription of the patient record. Okay, I want to return to that argument, but sort of let me first play devil's advocate and ask, do we really need to invoke laboratory science to explain any of this? Or can the changes that we see in the patient record by the 70s and 80s be traced to broader shifts in the ways that Americans after the Civil War of the 1860s went about organizing and conveying knowledge? That is, instead of looking for the influence of the lab on the clinic, maybe historical understanding might be better served by tracing changes in both to their shared cultural context. And certainly one can point to the increasing bureaucratization and impersonalization of American life, to the intensifying pervasiveness of standardization and the values of the factory in American culture in general. Frame this way, though, I've just got to say, the questions to me are just too intimidatingly large and vague. So instead, let me cite okay, my mouse has stopped working, never mind. Let me cite just one concrete example, that of an assertively unorthodox, in fact, anti-orthodox physician in Atlanta, Georgia, one Dr. Seaborn Freeman Salter. During the 1870s and 80s, Salter conducted an extensive private practice by mail in which rural Southerners wrote telling him the story of their ills. Born in rural Georgia in 1840, Salter became an eclectic practitioner and presented himself ideologically as a direct descendant of the populist botanic healer Samuel Thomson. In 1870, Salter moved to Atlanta, where he established and edited 3 botanic medical journals, published 15 books on his reform practice, saw patients at the Eclectic Dispensary, which he founded, set up a medical college where he both taught and served as dean, and manufactured and marketed such botanic remedies as Dr. Salter's liver pills up on your screen and his mother's cordial. Salter advertised his postal consulting practice in his journals at Popular Health Guides. As he said, distant patients are reminded that I can treat them just as well as if present by giving detail of symptoms. It makes no difference how badly written the body of your letter, I can master the contents. Yet the sick person was not to compose their narrative without direction. Thus, in and amongst this page of patent medicine advertisements in one of his journals, Salter posted this. Let me give you a close-up of it. This listing 16 specific questions for the patient to answer. Having received the sick person's account, Salter then would reply by filling in the blanks of a printed form letter, offering an interpretation of their symptoms, a diagnosis, and a course of treatment, almost always his own patent medicines that he sold. Finally, he presented his prognosis and specified his fee. With this letter, though, Salter sent a new form to fill in and return with payment. The one up on the screen is from 1883. These new forms pose questions similar to those in the consultation advertisements. But here, the illness narrative was to be strictly regimented, not only by the physician's questions, but also by the structure of the form. Fill in the blanks according as they suit your case, the patient was instructed. The final blank on the question, the one down at the bottom, state your present symptoms, brought the most gripping reports. Thus, the man who completed this form read, and I don't know whether you can read it, it's in unconventional English spelling down at the bottom. My disease is not bad, but I am anxious to get rid of it all the way I can tell I have got it. I kitch my water in my hand and see matter in it, or I mash the head and see matter. And then in the side margin, along here, he writes, I have filled the blank as far as I could understand. Others left gaps either because they didn't comprehend the information that Salter was seeking, or because they simply elected not to answer his questions. In the forms filled out by women, for example, the phrase have blank practiced self-abuse, that is masturbation, ordinarily were simply left blank. By using a standardized form and giving the patient only a little space to fill in their replies, Salter sought to structure the patient's story in ways that would make it streamlined and precise. He continued that effort on the back, on which was a printed diagram, one form for women like this one, and another for men. Men were instructed on the male form on the other side, mark with a pen the exact location of any soreness or course of any pain, location of any ulcers, skin eruptions, and so forth. Using such forms, Salter hoped, would enable patients with variable skills at producing a written narrative to localize the seat of their disease with precision. Diagnosis by letter was, as the medical historian Christopher Lawrence has called it, the epitome of narrative medicine. No physical examination was possible in epistolary practice. I mean, what the physician knew came entirely from the patient's words. Yet even though Salter's patients often told much of the story in their own words, despite his best efforts to structure their narratives, we see his clear preference for uniformity, standardization, visualization as a regimented format. We see his efforts to encourage terseness in expression in filling out the short blank spaces and precise localization on the printed diagram. We see, in other words, structural preferences strikingly similar to what we find in hospital records composed during these very same years. So, what to make of this? Does the formal aesthetic of clinical narrative that I've described for an elite orthodox institution like the Mass General have any relevance whatsoever to the standardized forms on which Salter's patients inscribe their accounts? On the one hand, in Salter's voluminous extant books, journals, correspondence, and lecture notes, the experimental laboratory is virtually invisible. On the other, it's clear that Salter's practice was not insulated from mainstream ways, as this 1880 sales sample of standardized clinical charts that I found in his archive demonstrates. And this is just what you get if you order the charts, which, as far as I can tell, he never did. Whatever significance we might ascribe to the model of experimental laboratory science in the transformation of clinical narrative, crucial as well were shifting conventions of writing and communicating information rooted in much larger changes in American culture. And yet, in this as in other things, I think we really need to listen closely to our historical actors if we want to understand the meanings that they attached to clinical change and choice. Speaking in 1900, at the 50th anniversary of the Women's Medical College of Pennsylvania, the eminent New York physician Mary Putnam Jacoby would exemplify the endeavor to identify the bedside with the bench, the clinic with the laboratory. Jacoby admonished young physicians in her audience to cultivate what she called the laboratory habit of mind, by which she meant not merely clinical use of laboratory results or of laboratory-derived instruments of precision, but more especially particular ways of thinking, writing, and knowing. The clinical record, she went on to urge, and this to me is the intriguing passage, the clinical record gains in value with every approximation to the ideal of the laboratory notebook. If we're dealing here even partly with an instance of discursive appropriation, it's one that has had profound biomedical and human consequences. What I'm suggesting then is that experimental laboratory science and the new ethos it emblemized, held out to clinical medicine not only new cognitive models, but also, and perhaps as important, new representational ideals. It brought to the practice of clinical narrative what might best be characterized as a new aesthetic preference. Judged by this emerging aesthetic sensibility, much of what had been part of the hospital record now seemed to detract from a concise history of disease and its management. The discursive stories patients once told were doubtfully relevant clutter and were trimmed away. Also trimmed away were physicians' subjective comments. And what historians of science, Lorraine Daston and Peter Gallison, have pointed to in other natural sciences as what they call the moralization of objectivity, here mechanical objectivity during precisely this period, I think finds a clinical counterpart in these doctors' new restraint from inscribing their subjective reactions into the patient chart. Indeed, the moralized virtues of self-restraint, of self-denial, became a hallmark of physicians who embraced this new version of scientific medicine, something that I think has attracted much too little attention from historians. Their identity was invested in a specific kind of image of objectivity, which they cultivated in the case record by aspiring not only to precision and exactness, but also to self-abnegation. New modes of inscription, the graphic method and standardized printed forms, along with the new instruments of precision, were extolled for furthering the ideal of eradicating from clinical narrative the person of the doctor observer. Like modernity itself, defined in significant measure oppositionally by what it was that it excluded, this emerging persona of the scientific physician was characterized as much by what it eschewed as by the ideals of precision, exactness, objectivity, and uniformity that it embraced. When back in 1866, the young New York physician Edward Sagan published this form, which I showed you earlier, what he celebrated was its escape from the senses of the observer in recording what he called objective signs. Sagan's physician father asserted that, I'm quoting here, the results obtained by the instruments and methods of positive diagnosis are given out by the instrument itself in traces, figures, or diagrams, which the imagination of the observer cannot alter, nor his power of rhetoric enlarge or color. What the thermometer says, no man can contradict. For physicians, the younger Sagan, his son, went on to proclaim, thermometry is not only knowledge, but social power. It really kind of sounds like the kind of sentence that we would produce, but this was him in 1866. By the 1880s and 90s, as precise measurement of temperature and charting of vital signs became a nursing task, some physicians even began to speak of the reliable, new, trained, professionalized nurse as akin to yet another mechanical recording device. And indeed, by the early 20th century, one would begin to hear protest like that from one nursing leader who lamented, in her words, is the word nurse going to degenerate till it means only a superior kind of machine? The physician's educated senses, the experienced observer, still won praise. But what was new from the 1860s and intensified through the end of the century was a countervailing and remarkably pervasive call to liberate medicine from a doctor's individual observation and personal judgment. From sphygmograph to X-ray, each new instrument introduced during this period would in turn be lauded for, as another physician tellingly put it, for eliminating the personal equation of the observer. What another clinician demonized as that unbidden guest that sneaks into our laboratories and clinics and confounds the senses of the keenest mortals. So if this interpretation is even partly true, perhaps we can see a new framework for understanding what happened to the sick man and sick woman who once had been so visible and vocal in the clinical narrative. The new order demanded that the voices of the individual patient and individual physician both be muted. Into the first decades of the 20th century, the formal changes I've recounted here, for the most part, persisted, but there were some notable changes, alterations, especially in scale. From constriction, the clinical chart started expanding in length, reflecting not some return to discursively rich prose, but rather a proliferation of standardized forms, test results, pasted in graphs, sigmographs, and photographs. A pastiche that made the still-bound casebooks start to resemble scrapbooks. And to the point that for the historian sitting in the archive working with these, you got to be careful because the little bits and pieces, as with an old scrapbook, start falling off, and you start getting really nervous about what the archivist is going to make of this. And at some institutions, the bound volumes started to be replaced by the individual file. Nevertheless, I want to suggest that early in the 20th century, the formal aesthetic for clinical narrative that I've described for a large hospital like the Mass General was infused in the wider fabric of American medicine. And one reason is that the epistemological, aesthetic, and moral canons for keeping an admirable record that had taken shape among a clinical elite in the late 1800s remained ascendant at the moment when, in the 19-teens, the clinical chart became the centerpiece in the hospital standardization movement. The newly created American College of Surgeons, founded in 1910 and committed to fusing scientific medicine with scientific management, was initially the most powerful engine of change here. The college regarded the clinical charts as, in their words, not merely a clerical procedure, but the very index of success in all clinical work. Yet a 1917 college report survey concluded in about 75% of the hospitals in this country, the record as it is kept today is practically valueless. With backing from the AMA and the American Hospital Association, the college launched a crusade for standardizing record keeping nationwide and pressed for minimum standards in all branches of medicine, not just surgery, establishing the forerunner of the current hospital accreditation system. Medical men have been standardized, a college report proclaimed, alluding to the aims, if not the realities, of the educational reforms that followed Abraham Flexner's 1910 report, urging that now was the time to standardize their product with the uniform record, the one best system of medical narrative, as the most reliable gauge. And yet, starting in the 1890s, a subtle but important change had begun in the ways that some physicians spoke about the sufficiency of what Jacobi had referred to as the laboratory habit of mind. This was the emergence of what we might call a kind of discourse of deficiency, that is, a lament, sometimes a jeremiad, about what was missing or at risk of going missing in the new version of scientific medicine, and more especially in the medical persona, in the clinician. While celebrating the gains brought by this new medical order, doctors warned that mounting aspirations to precision, to making clinical medicine an exact science, were edging out what they called personal knowledge and personalized medicine. Those are their terms. And they began to speak up for clinical virtues that had been marginalized, forgotten, or sacrificed, such as individual experience, the educated senses, personal judgment, and cultivated medical artistry. They were making the case for something in addition to, not instead of, what the new experimental sciences were bringing. This was really a matter of dissonance, not of dissent. The impulse to escape the reign of personal idiosyncrasy, for example, began to be met with apprehensions that something important was being lost. And I know there's no time to explore it here, but while the personal equation, that term, was still denounced as an impediment to precision to be eliminated, it was in the 1890s that you also start hearing physicians using the term in a newly positive sense to refer to clinicians' personal judgment and personal relationship with the individuated patient. It was at this moment in the 1890s when clinical acumen prominently came to the fore as a way of capturing what distinguished the physician artist from the mere technician. So too, while the art of medicine retained its earlier connotations, more and more art came to stand for ways of knowing that had become missing or fragile or increasingly undervalued. Even within the College of Surgeons, critics protested against overly rigorous standardization of the medical record and moves to bring the methods of the efficiency engineer to the clinic. At the college's 1919 Standardization Congress, for example, a Brooklyn doctor proudly announced that he'd been invited to give the opening address at that year's meeting of the Taylor Society. That is a group committed to promoting Frederick Taylor's program for scientific management. To which a really irked, a really pissed off Chicago clinician reported that efficiency engineers would make no headway in the clinic because, in his words, because they are trying to do it by mathematics or by mechanical means. We all know you cannot standardize an art. More intriguing and consequential was the new development of the language of art by some college leaders just after the First World War. Insistence upon standardized case records, the director of the college asserted, in his words, in no way reduces the practice of medicine to a machine-made process. The entire process is human, and the records are human documents. Good records have something in them that can be made in no mill. Here was a rhetorical re-embrace of individual judgment as a hallmark of professional identity that earlier moves had sought to banish. It was precisely such attention to the art of medicine and exercise of individual judgment, I'd suggest, that was to set the new modern scientific clinician apart from the factory worker on Henry Ford's assembly line to make the clinician more than merely a highly trained mechanic or technician, and more than the newly professionalized nurse. And I have to say that I've grown especially intrigued by the extent to which physicians' new celebration of art and of clinical acumen was in part propelled by professional nursing's growing claim to scientific expertise, standardization, and precision measurement that physicians had once held up as hallmarks of their clinical work and their professional identity. All right, to wrap up. These observations might invite us to look ahead toward the holism of the interwar period, for example, and to deliberate efforts to restore the patient's voice to the clinical chart. And in the book that I'm now writing, while I've decided not to pursue the patient chart beyond the period that I've spoken about here, what I am tracing are physicians' broader anxieties and responses to reductionist hubris. Some of them would lament by the 1920s, for example, about the specter of what they called assembly line medicine and of doctors reduced to robots, a new term coined in 1920. And they would complain by the 1930s that modern medicine was losing sight of the patient as a whole the patient as a human being, the patient as a person. All of these, their terms. This was a context for efforts to refashion professional identity in ways that reaffirmed the importance of clinical acumen and strivings to re-enchant the art of medicine in an age of medical science. But I just want to close by returning to the patient chart and to the final third of the 19th century. Instead of one stage in a linear passage toward modern medicine, that period really stands out as a particular moment when those clinicians who had given their hearts and minds to the new sciences were singularly captivated by the promise of precision, exactness, automaticity, and simplicity. Their proposition that science could render clinical medicine mechanical, far from being a source of anxiety, for them had been a vision to be pursued. It might or might not bring to mind evidence-based medicine. But for them, it was a fulfillment of a dream to eliminate the personal equation and bring clinical certainty. Their early 20th century successors, while no less committed to the experimental sciences, were less intent on marginalizing clinical ways of knowing that seemed to go against the grain of reductionism, and began to reclaim a cardinal role for clinical judgment in professional identity. Yet, to a remarkable extent, it was the more exclusive set of epistemological and aesthetic allegiances, one might say moral allegiances, of the late 19th century, both cognitive and material practices that were expressed in aspirations to mechanical objectivity and silencing the voices of both doctor and patient alike that were key in transforming the clinical chart. When it is that historians refer to the voices of our subjects, to their speaking or to their silence, as often as not, we invoke voice to stand for power, as a metaphor for power. Well, whatever association we might want to make between voicelessness and powerlessness in the case of the sick in this period, in the instance of late 19th century physicians I've explored here, that conventional correlation was completely turned on its head. The new program that held up self-abnegation as a professional virtue celebrated the silencing of the doctor's idiosyncratic personal voice as a source of clinical and cultural empowerment. Equally, I propose that we probably ought to start rethinking a too easy identification of the reductionist aesthetic and muting of individual voices with dehumanization. Individuality is still expressed in these late 19th century records, although in a different language and attuned to different indicators. More than this, are we really prepared to see the disappearance from the case record of doctors' subjective judgments on patients' moral habits, sexuality, or ethnicity as dehumanizing? I mean, in a strict sense, yes, but not in the sense in which we usually would use the term. At the very least, in the story that I've sketched here, we see the origins of clinical habits of mind that physicians and patients, I think, have grappled with ever since. To understand the shaping of modern medicine, I do think it's crucial to recognize the practice of writing, be it on paper or electronic, to recognize the practice of writing as one constitutive element of the practice of medicine. More than this, changes in that practice, whatever their source, not only reflected broader shifts in the ways that clinicians view patients and their diseases, but I'm beginning to believe also played a key and active role in reshaping their conceptions both of patients and, as important, of themselves. And I'm going to stop talking with that, and thank you for being so very patient with me. And also, I think I will probably stop sharing my screen, though I can always pull it up.
Thank you so much.
Now I see a sea of faces, which is what always you miss on Zoom.
Peggy, can you hear me?
Yep. Yeah,
Please.
that was an amazing talk. It's so interesting. And I'm just curious about, I know you didn't want to really go into how wider society changes influenced this transformation, but I'm curious about the other way around. So how did this influence society's views of people who seek medical care? And that's too big a question. So I thought I would narrow it down to people with disability. And when I read Kim Nielsen's Disability History of the United States, the impression I got, you know, I could be right, could be wrong, but the impression I got was that back in the 19th century, there was just a story around a person who was missing an arm or a leg, and they were fully integrated and they weren't made into this other thing that had this special relationship with the medical establishment. And certainly by now, that's completely not the case. Now they're patientized or something. I don't know. Could you comment on that?
Whoa, just a little bit, although I'd be inclined to make this into a seminar rather than a quick answer. That's a fantastic question I actually hadn't thought of, and I'm chagrined that I hadn't. But I think the first thing that would come to mind is that, you know, I do think that this is to a very large extent where I would say you start seeing, oh dear, my domestic partner also does disability history, so I'm speaking very carefully here. But I do see this as as a period in which a certain element of the medical model rather than a social model of disability starts to get in place. And the way that I see that in particular is that, and I know this better by what happens by the 1920s, though it's there earlier, that alongside this anxiety and language set of worries about converting the doctor into a robot, into something mechanical, there's also a parallel discourse about turning the patient into a robot or regarding the patient as a mere machine. That term, mere machine, comes up again and again and again. And it also goes back to the idea of the kind of anxieties among physicians that was wrapped up of seeing the patient as yet a machine on the assembly line. There are a lot of parallels about Ford's assembly line and what we don't want medicine to start looking like. So, you know, I would welcome whether that matches your understanding of things, but I do think this preoccupation, both preoccupation, but also set of worries. I'm more interested in the set of worries and apprehensions, but starting to see patient as a machine that does get forged in this period does map on to what you're asking about. I don't know whether that makes sense. And do please follow up if it doesn't.
Oops, I don't want to monopolize, but I think that does make sense. More to be said, but yeah, let me give way to our colleagues.
I was just going to say something. I thought when I was listening to your talk, several points came to mind. First of all, it's really interesting to me that we're in a new phase of the patient narrative in the fact that patients are now reading the electronic medical record. So it's changed the dynamic from the doctors using like language that's coded and at times obfuscates. And now we're in a new world where patients are going to read the record, give us feedback, and it totally changes the doctor-patient dynamic. So that's one piece. And the other piece is interesting. I think we now are in a time where doctors and nurses, speaking of generalized anxiety or generalized anxiety disorders writ large, is I think both doctors and nurses are in a period where they both are under siege from kind of healthcare providers and extenuators that don't do the same thing that they do, but institutions are trying to have cheaper alternatives to physicians and nurses, and have nursing, these medical assistants, and then all the layers in between. So I think it's interesting to be looking at the anxieties that change brings with it.
And it brings up, this would be a question for you about how much you think that a different audience changes the way that you write the patient record, what you include, what you don't. Audience is key all the way through here. It's in the 1880s that at the New York Hospital, for example, you start to see requests from lawyers to look at the patient chart. And that gets very quickly, it very quickly changes within a period of 5 years in the 80s, from handwritten letters from attorneys to a printed form that the hospital gives the attorney to fill out with the request. But I think, while I'm focusing on this earlier period, I did, just as a busman's holiday with a young psychiatrist who was doing a master's degree with me. He was working with a psychotherapy group at the local VA here in West Hartford. And his psychotherapy group was interested in narrativity and the patient chart. And so we got together one day and completely as a busman's holiday for me, looked at the patient charts for a period just before they moved to the electronic record and just after they moved to the electronic record. The difference being that after the electronic record, there was the possibility of immediate oversight. As they framed it, there was the possibility of oversight from Hartford in a way that there hadn't been before. And what we noticed, we sat around predicting the sorts of things that we might find, not expecting them actually to be actualized. But two of the things that we noticed that immediately and across several sets, the clinician changed from the word I to the word the therapist. There was a distancing from things. And the other thing that vanished that they noticed and I wouldn't have was a phrase like, Joe seems better today. And as they interpreted that, if you write that Joe seems better today, rather than remembering that Joe seemed better today, then Hartford might decide, well, maybe Joe doesn't need continuing coverage of this kind of treatment because he's improving. So there was a reluctance to put that into the chart. So just as, and I could riff way too much on the audiences for these early records for the young physicians who inscribed them, but I just sort of take that as another way of how the envisioned audience, whether it's going to be a patient now or financial oversight, or the senior clinicians who were key for my group, how the envisioned audience changes the way you construct a narrative and how you write the patient record.
Thank you.
Of course, I'd be fascinated from the perceptions of those of you who are clinicians. The only patient I know is when I look in a mirror, and that's not helpful.
Dr. Silov, please.
Wow, thank you so much for a really exceptional talk. And there are a number of episodes, it seems, where history repeats itself in a, unfortunately, maybe predictable and maybe avoidable way. I was a chief medical officer for a large health system, and a few years ago when open notes was a new thing, there was essentially identical pushback to reducing the information asymmetry, increasing the transparency of the record. Open notes means that patients can see their notes whenever they want, and in the form that you write them. And there's a lot of pushback on the part of our physicians to doing that. And the words that I heard and the sentiments were very similar to what happened when the American College of Surgeons started doing quality work, and even before that. So that recurrent issue was really interesting to hear. So my question is, is this just the inertia of the status quo and a recalcitrance to change? Or and I wonder if when we were doing it, my thinking was that there was a fair bit of fear about being sued, a fair bit of concern about billing practices, especially, and how the patient's access to the chart would get in the way of their ability to send bills and that sort of thing. So do you see in that history a inertia of the status quo holding information asymmetry as a professional value versus leveling the playing field? I guess that's my fundamental question. Thank you.
Oh, I really appreciate the question, because it gives me one more thing to think about. I think, it sounds to me like it again sort of refers back in part to the envisioned audience, and how the audience, whether it's an attorney or the patient who now has ready access to this, changes things. I guess, could I turn it around and ask a question of you?
Yeah, of course.
When I early on in thinking about this stuff and giving a talk about it, it was a medievalist who asked me the question, okay, well, where did the stories go? If you see the sort of quirky, sometimes deeply empathetic, sometimes disturbingly judgmental notations about patients, and the move those from the chart, what happens to them? Because half of my life is in a medical school, and I know the stories about patients haven't disappeared. So where do they go from the chart?
Well, that was maybe a version of an answer to that relates to the terminology that's used in the chart, and what's the point of the chart. And the example that would come up, well, I have to stop calling people grossly obese. Well, yeah, why don't you stop calling people grossly obese? Because number one, that's not a medical term, and number two, it's insulting and really doesn't convey any sort of positive interaction or helpful interaction with our patients. And if medical jargon is what gets you through the day, then that's fine, and be prepared to explain it to your patients when they say, what does it mean, X, Y, or Z in my case. So what we looked at it is the story is meant to really level the playing field and incorporate the patient into the therapeutic interaction, whether it's a cancer patient, a heart patient, or even psychiatric patients. We have had open notes. I don't work for that organization anymore. Open notes for psychiatry patients. And they actually were the first ones to go onto open notes because they felt that the therapeutic interaction would be made better by that sort of work. So I think the story is going mainly to the patient and less so as a communication, solely communication to colleagues. It's meant to bring everybody into it at a more equitable level.
Thank you for this. This is really helpful for me, and suggests that there is. I hear behind this. Sorry, you moved on the screen, so I'm looking over here. That along with this, that the hint that the way that you write a patient record or with open notes, the ways that you write about the patient does enter into and alter in subtle ways the doctor-patient relationship. Is that?
There was a concern that that would happen in a negative manner, and what was found is that essentially always it was in a positive manner.
Yeah.
Fantastic. Thank you. Dr. Gata from Duke, please, Dr. Gata.
Great talk. I want to piggyback off of this conversation about open notes. One theme that we have had seen in mortality conferences is some degree of compromised truth when it comes to templated notes. So there was a time when physical exam findings would be performed because of the free text, the doctor wouldn't have written them down. And now we have templated notes and do these physical exams actually. And we've evolved from kind of like validating what actually happened because, we template everything and copy forward everything. Is there any evidence that open notes where the patient being able to read them that has improved at least the accuracy or knowing what actually happened in the patient encounter?
That has to be a question for you guys.
What we found in our organization and what the open notes community found is that actually it improved the quality of the notes. One of the concerns was that patients would be constantly pinging you to change something in the note. And what was found is that happens, but it happens in a very positive way. It's actually, going from right to left because it actually was left and you put right in the chart, that sort of thing. So, and it is actually improved communication when you have access to the hospital chart. So if you're in the hospital, you can look at what your team said about you. If you're in the intensive care unit, you can look at that if you're capable of it. So the thinking is, in general, it has been very positive and has saved people time and saved people errors by virtue of that. Does that get at your question?
Yeah, I think it does. I mean, I think that what we'll see in morbidity and mortality, for example, is a patient may come in for vaginal bleeding for whatever reason, and people free text or people template a note saying a physical exam was performed. I mean, there may have been like florid cervical cancer seen from the but like the note says normal cervical exam, etc. Because we have kind of adopted this idea of templating notes and copy forwarding outdated encounters that we're pulling in information that is inauthentic, and it's within all the medical noise created by the electronic medical record. You do compromise some degree of authenticity. So it's more of a comment than a question.
Thank you so much. Dr. Van der Heide from the University of Iowa, I think, is here to ask a question.
Thanks
Okay.
for a fantastic, really interesting talk. My question is also sort of on this topic of us discussing the new open notes phenomenon. And I'm just curious, so there's been a lot of discussion about with notes being more accessible to patients about what the purpose of the medical record is. Is it a scientific document? Is it a legal document? Is it a document to communicate with the patient? Particularly, just as a side note, running more and more now into issues with different understanding of medical language by patients. So I completely agree with Dr. Silop's point about saying things like, grossly obese, that doesn't serve a purpose. But I've also seen cases where, patients will get very upset and it will damage the doctor-patient relationship because somebody wrote spontaneous abortion in their note after they had a miscarriage, and they say, how dare you say that I had an abortion? So in any case, that's one of the things that I think is interesting in this whole topic. And I was thinking of as Dr. Gata and Dr. Silop were talking. But my question is, what you think that the purpose of the medical record was when it was originally devised centuries ago, and if that purpose seemed to have shifted significantly over the period of your study?
Yeah, I love that question.
You're
And
fine. What a good boy you are. Good.
I wish that that were directed at me. Um, yes, absolutely. I like the question, and it does change or began to change during the period I'm looking at. It's got to be said that for most of the period that I was talking about with the early 19th century, even through the late 19th century, these records had more to do with, well, let me flip it on its head. They had less to do with patient care than with other things. And I guess it's the most bold evidence I bring forward of that. Very often, these were written up only after the patient was gone. The patient had been discharged, or the patient had passed away. Why then did these matter? Well, they could matter as notes for research or basis for publication, sure. But they also mattered as a way, I'm going to put this in a way that might sound flip, but I don't mean it to be flip. These were bound records that lined the boardroom of the hospital. They were a statement of what the hospital does, what we have collectively accomplished. It was part of the identity of the institution and of the physicians who were there. They clearly played a role in clinical care, but as much as that, for the young house officers who inscribed them, this was a way of showing themselves to be, how to say, again, if I say jumping through the hoops, it might sound flip, but I don't mean it to be. That they were thinking about the case, that they were thinking about things and approaching it in a way that was au courant with the medical forefront. And it's very clear that, you know, a lot of what isn't in the patient record was held in the mind. I'm thinking of one set of correspondence between Bowditch, a clinician at the Massachusetts General, and a patient, that the patient follows up in a very unconventionally spelled and written letter saying, "This has happened to me since I left the hospital 6 months ago, and what do you think about this?" And the clinician has a very good detailed recollection of the case, but there's no way that you would know that from the patient record that was actually preserved in the bound books for the Mass General. It was held in the mind. So I don't know whether that begins to get at your question, but the purposes do start changing here.
Yes, thank you. The other thing that I just observed as interesting was your point about it being used as a means to sort of evaluate house officers and trainees, because I think that that's one of the roles, whether it's intentional or not, I think that's one of the roles of the medical record that has not changed much.
Interesting. Not surprising, but interesting.
Professor Dalton from the Denver Health Hospital, who interestingly did her law degree and PhD in where did you do it?
Well, the law part was from Edinburgh University in Scotland, and my
Scotland, yes.
PhD and fellowship was from Yale with Professor Steve Latham.
Yes, I was going to say that, but you had done your ethics work at Yale. So please.
Both a colleague and somebody who lives 3 doors down from me.
Well, actually,
right?
I'm in Denver, so. But thank you so much for this wonderful talk. My question is with respect to learning whether there has been any studies to look at patients' personal narrative medicine stories and how can we integrate these personal stories into the medical records to improve the health, the delivery of the medical care, especially when it comes to end-of-life stories. Majority of these patients, based on my experience, were Holocaust survivors, and they're the younger generation. When they speak of their grandparents or great-grandparents' wishes are completely different than the younger generation. So how can we integrate that into the medical charts?
Well, first on sort of wearing my historian's cap and placing narrative medicine as a movement. That as I look at this long trajectory over time, clearly to me one function of narrative medicine from the outsider's perspective is precisely to retrieve the kind of stories, the kind of patient's voice, the kind of experiences that were programmatically jettisoned from the chart in the period that I've talked about. How can that be integrated in the patient record now? I think that's one of those points that I have to turn this into a try to turn it into a seminar again, and point it back to those of you who live at the interface of clinical medicine and record keeping, and who have engaged in serious ways in narrative medicine and what it yields. Is that an integration that you've seen, Dr. Dalton?
Yeah, I personally think, like I said, especially when it comes to end of life cases or decisions, it would help tremendously if in case the patient has failed to designate a decision-making process. It would help us sort of like understand where they're coming from.
I can see that, yeah. Thank you for that point.
Thank you. Dr. Marber.
Hi, I'm Kate Marber, not a doctor. I'm thrilled to be in these august surroundings. I mean, interestingly, building out of the last question, I'm a second-year master's student in narrative medicine at Columbia. And, my question was, and I think the first part's been answered, how was narrative captured? But moving forward, because of the work that I'm doing and being exposed to, particularly with stories of chronic pain and illness and disability, I wondered what you were seeing and observing now in how those stories are being captured, or some of the initiatives to capture them, because of the dialogue between clinician and patient, and the amplification of those voices and stories changes the dynamic and the relationship between clinician and patient, particularly with marginalized groups.
Well, again, I have cut myself off at the beginning of the early 20th century. So, I mean, frankly, what happened is I was working on this project and I thought I was going to write a book on it, and it triggered questions that I found way more interesting than the patient record itself. And what can I say? Life is too short, so you sort of go with that. I can address that in a really tangential way, talking about my period rather than now. And it sort of goes back to that question from the medievalist of where did the stories go? And where many of the stories went for the period that I'm talking about, or in the first few decades of the 20th century, was to social workers. The other thing that I would throw in, though, is you also see during the interwar period, during the 1920s and 30s, starting in the teens, but really 20s and 30s, you also see a move to have medical students, to have trainees recover these stories. And often this was something that medical school deans, medical educators try to institute with things like home visits, where the student would go into a patient's home and would do the kind of interview that would produce the kind of experiential narrative that you're talking about, with the idea that this would change them as practitioners in future as well. So I know that's a century off for the question that you're asking, but it's with the limitations of the century that I know.
Thank you.
Thank you. Dr. Jamil,
Yes.
please.
Thank you, Dr. Seguin. Dr. Warner, I just wanted to get your thoughts on, Neil Postman writes extensively, building on this concept about how the medium is the message, and how digital media can have a different impact on the person deriving information from it, because typography requires a person to sit still and read, and their imagination creates the information that they're reading, whereas digital media kind of hijacks this process. I would consider the electronic medical record to be somewhere in between digital media and typography. But I would love to hear your thoughts on how you feel like the electronic medical record has changed the relationship between the doctor and patient, just because the medium through which they're transcribing their notes is different. When a physician writes a note physically, that has got to be different than the process of clicking a button that auto generates a note for them. But I would just love to hear your thoughts on that difference.
Well, I'm largely, again, inclined to shift my hat from historian to ethnographer, which has to do with your experience in writing it as opposed to clicking it. Certainly, again, my naive outsider's perspective, there are so many studies that have shown for school kids, for example, how writing some, excuse me, that's a landline that I don't know how to turn off. For school kids, how writing something changes the way that you think about it and what you're going to remember. Whereas clicking something, especially if it's a matter of clicking something to copy and paste it here, it's making it part of the new record, but you don't, and I say you don't, I can't say you don't, I'm just telling you what my naive guesses would be. You don't think about it or absorb it or reflect it in the same way. And, word on the street is that so much of it is a matter of click and copy in producing things now. My informants may be wrong, but still.
No, I think that's absolutely accurate.
You know what I'm thinking? I'm thinking that we're doing these intense questions, which have been fabulous, that we will not break off to go back onto another system with Professor Warner, but just stay here with the questions as they're being brought up. While people are considering the questions, I wonder if I could ask you one question, John, and that has to do with this final third of the 19th century. My question is, in your view, with the changes that occurred in the United States, US changes or were they influenced by, the book that you wrote on the French impulse in 19th century American medicine, but also in that third half of the 19th century, the increasing use by American physicians and teachers of German system of healthcare. Did the French or the German systems affect us, or were these our developments?
No, I think the question is spot on, but in different ways. I think the French influence, those Americans who, between the 18 teens and 1850s, physicians and students who went to Paris to study in the Paris Clinical School, I think what they brought back was an impulse simply to keep the record. And I think that the move to keeping a fuller patient chart here was part of their Parisian medical identity, to the point that I know of at least one Philadelphia physician who returned to the Philadelphia General Hospital and kept all of his patient notes in French, pretty bad French. He was not a Francophone American, but to him, keeping a record, was part of what he had taken away from the Paris Clinical School. With the move of American physicians and medical students, the massive move to German-speaking countries after the 1870s, I think this is where new models of clinical specialism, often centered around the use of new instruments, the ophthalmoscope, and so forth, combined with an allegiance to the idea that experimental laboratory science is going to transform medicine. I think that's very much the impulse. That German impulse is what I see being instituted here. When I thought I was going to do this as a more expansive, keep the focus on the patient record, I did pretty extensive research in the manuscript patient charts of Scottish and English hospitals, and also some in Sweden and Denmark, and Germany. And I think you see the strong influence and modeling of the Americans on the Germans, expressed in the records, compared, for example, with the English records, which change a bit, whereas the Scandinavian records are very much drawing on German models, and often German forms, or forms that are printed for German hospitals that are taken up and used. I think Americans are really following in train with where they see the cutting edge of medical science. Paris early on, the German centers later on. I don't know whether that starts to answer things.
No, it does very, very well, yes. Of course, the dominance of Johns Hopkins, which started around 1891, based largely upon German training for their 4 or 5 leaders. Daniel Kim from Albany, please, Daniel.
Dr. Siegler, thank you so much, Dr. Warner, for that wonderful talk. And my question, so I was really intrigued by sort of the way you described, I think you used the word aesthetic preference, this sort of move toward, standardization and preciseness. And so the term sort of aesthetic preference makes it seem like it wasn't necessarily grounded in good reasons. And I just wanted to sort of confirm whether that in fact was the case, or were there efforts, even retrospectively, right, to justify this sense of aesthetic that they had, or preference as you describe it. I mean, were there efforts to argue that, you know, this is important for good patient care, or concerns that there may be harms if, you know, they do otherwise?
Thank you for the question. So I should explain how I got to the term aesthetic and what I mean to capture by that. This was simply a process of me grappling with the patient records and trying to understand how can I characterize the changes. And I could easily trace changes that are technological. I could easily trace changes that are epistemological. These are familiar territories for me and in my other work. But there was something else going on. There was something that has to do with what does a good record look like? And I guess by using that term, I don't at all mean to trivialize what's going on there. But it's why I use the word, the comparison with haiku, that you know, the form itself has an appeal. It's not just the words, it's not just the content. There is something more, not instead of at all, but something more that is witnessed and experienced in reading a haiku. And it seems to me that something was going on as well in the clinicians and their decision-making and their preferences. Now, I mean, in a way that goes back to audience, or can be referred back to audience, and you know, are you doing something that in addition to being technically and epistemologically cutting edge, correct, what else do you want to be able to present to a senior clinician? Which you can also see in the very, very, very wonderfully legible writing of these patients or of these patient records. They're easy to read, which I won't go to crude jokes about physicians' handwriting, but that's not the case here. But also, I think there may be better ways of describing it, but they're also what to me seemed like an aesthetic dimension in the ways that, aside from an audience that might include a senior visiting physician, had to do with the person writing it itself. It tells them something about who they are, what they've become or are becoming. So, you know, there I'm sure are other languages that would capture that. But this is the closest that I was able to come to. And also, I put it together with work that I've done in other ways in which the aesthetics, again, what I call aesthetics of modern medicine, were expressed, be it in you know, changing photographic conventions or changing architectural preferences.
No, thank you. I found that compelling. So what I'm hearing you say, though, is that there may have been sort of practical, sort of medical considerations at play, but this aesthetic dimension is an important part of that, and basically interlinked, right, in some way with the practical considerations.
That is certainly how I have come to read them. And just to, I know, repeat, but to be absolutely clear, it's not instead of those practical things. It's something in addition to, on top of.
Very helpful. Thank you.
Thank you.
Thank you for the question.
Jay Carlson, did you want to ask a question? No. Mindy, are you still on board?
I'm right here. No,
Yes.
that was terrific. It's great. There was some other questions from the chat, but I don't know. If I think so many things have been answered. There's a lot of. Oh, this was food for thought. Here's what Martin Chan wrote. With the rise of AI diagnosis and tech such as Google Forms, is it time to revert or at least rely on more standardized forms of history taking as opposed to freestyle oral history interview? I don't know. I think this goes back and forth. I'd be interested in hearing, but I think we go back and forth between standardized and, freestyle. I think one of the interesting things when I was listening to you, John, was about the issue about you were describing one of those 19th century histories where one of the first things they did is write what the person does, like this 26-year-old laborer. And the interesting thing that's totally missing from the 21st century chart is that it almost never has like what the people do. It's fascinating. So I'm just going to respond to that.
Well, and of course, another dimension to all of this is simply time.
That's the big dimension.
Yes.
Could I ask a self-interested question of Dr. Gata?
Dr. Gata?
You use the phrase compromise authenticity. Is there something that you could suggest that I could read that uses that language?
This came from billing, right? So when coders are looking at the physician's notes to say, well, what happened in the clinical exam room, when they sat down with those who bill, they said that 30 years ago, they couldn't bill enough because physicians didn't document enough about what happened, right? Now, so that they couldn't bill, for example, like a cardiovascular exam because the doctor wouldn't have put it in the note. They would have, put other, they would have, if it was normal, they would have excluded it, for example.
Yeah.
Now, with like the notes being like 10 pages long and just all these exam findings that are achieved by sitting in the chair, the billers don't know what had actually been attained in the clinical patient encounter. So the comment wasn't based off of something that I've read. It was based off of the comment that billers were making that they don't know what truly happens in a physician-patient encounter because the notes make it look like we've been in there for 10 hours with the patient.
Yeah, yeah. Thank you for that. This is this is helpful grist for my own mill.
I don't see or hear any additional questions. What I want to say is I want to thank Professor John Harley Warner for this extraordinary talk. I want to tell him that we're all eager to see this book called The Quest for Authenticity in Modern Medicine. When might that come out?
Oh, my graduate students know that that's a question to ask and then duck. It's going to be a couple of years. I have 7.5 chapters drafted out of 9, but there's a lot of standing back and reflecting.
Well, we will wait and be excited for that and hope that you'll come back and meet with us, maybe even before that comes out.
With great pleasure.
But I want to give you my deepest thanks and that of the audience today who were wonderful. And I so appreciated their participation and their questions. Thank you so much.
Yeah, well, thank you to you. This has been really helpful.
Thank you.